Good morning. I'm Tony Shi, President of United Hospital Fund. And on behalf of UHF, it's my absolute pleasure to welcome you to our 14th annual Medicaid conference. After 2 years of hosting this event virtually, we're delighted to offer this in hybrid format today. It's actually a first for us for this conference. It's great to see so many of you in person, and a warm welcome to those of you joining us online as well. Another first this year is hosting an in-person event with no registration fee. We believe that waiving the fees this year was important to increase access to this convening, and it's only made possible through the generosity of our sponsors. I want to call out our lead sponsors, who are the Commonwealth Fund, a private foundation whose mission is to promote a high-performing healthcare system, and of course, the New York Academy of Medicine, a leader in public health innovation and whose mission is to drive progress towards improved health through attaining health equity. We'll hear from both organizations later, but I encourage you to go to their websites and learn more about the amazing work that they're doing. And of course, a sincere thanks to our other sponsors as well, Medicare, Manat, and Unite Us. I did a quick scan of the registration list, and it was wonderful to see so many longtime friends of UHF joining, as well as a large group of new names. For those of you that are new to UHF, just briefly, we're an independent nonprofit founded in 1879, and our mission is to build a more effective and equitable healthcare system for all New Yorkers. We do that through research and policy analysis, running fellowship and demonstration programs, and convening stakeholders around pressing issues in healthcare. At UHF, we focus on three critical issues in the healthcare system: expanding insurance coverage and access to care, improving the quality, equity, and efficiency of care delivery, and addressing health disparities by fostering collaborations between the healthcare system and communities to address the broader determinants of health. In our coverage focus area, one of our longest standing programs is the Medicaid Institute. We established it in 2005 to help strengthen and improve the Medicaid program through research and policy analysis, as well as public activities such as today's conference. Before I go through the agenda and logistics for today and introduce our keynote speaker, let me just briefly set the context for today's meeting. As most of you are aware, enrollment in the New York State Medicaid program has soared during the pandemic. As of April 2022, there were 7.4 million New Yorkers enrolled in the program, well over 1/3 of our state's population. You may hear some critics of the program complaining about its size and scope, but the fact is the program overall is working as it was intended. It was designed as a countercyclical program. Enrollment and spending increases when there is a downturn in the economy, such as that caused by the pandemic, where there were job losses, losses in job-based insurance, as well as growth in the low-income population. Given the utterly fragmented nature of the US health insurance system, Medicaid serves as a vital health insurance safety net. Without it, we would see higher rates of people foregoing needed care, as well as incurring catastrophic medical debt. Access to needed healthcare is a basic human right, and although we fall short now, we as a nation would fall that much shorter without the Medicaid program. I should also note that the benefits of Medicaid coverage extend beyond simply providing access to care. Evidence suggests not only a positive impact on health outcomes, including lower mortality, but also improved financial security and reduction of food insecurity and housing instability, both which of course are important components of overall health and well-being. And despite the claim that Medicaid is a disincentive for employment, on a statewide basis, Medicaid expansion is generally associated with gains in overall employment. The growth of Medicaid yields another important benefit. Because our health insurance system is so fragmented, individual commercial payers have limited ability to shape care delivery. However, because Medicaid has become such a large payer, the program has emerged as a key driver of healthcare delivery system reform. And of course, an important mechanism by which reforms are driven are through the 1115 waiver. Today, you'll hear more about the proposed Waiver Amendment and other efforts of New York Medicaid to drive health system improvement. We'll start with a keynote speech from our New York State Medicaid Director, Amir Basiri. We'll then transition to a panel focused on the work in the Rochester Finger Lakes area, which is a potential model for the health equity collaborations that are outlined in the draft waiver amendment request. After lunch, we'll have a fireside chat discussing the types of community-based organization collaboratives that are also mentioned in the proposed waiver amendment. And then we'll transition to an afternoon panel that'll focus on the health needs of those who are incarcerated and being released from incarceration. Of course, a conference like today requires the work of many. A big thanks to the staff at UHF, including Kathy Arnst, Emily Arson, Giovanna Braganza, Alex Brandes, Hillary Brown, Adam Fifield, Miles Finley, Gabby Grenke, Hollis Holmes, Emily Regas, Joey Rodriguez, Sally Rogers, and Chad Shearer. Just a few logistics. We encourage questions during the session today. So if you're in person, there are mics in both aisles. And if you're online, please submit your questions in the chat box. During the Q&A portion of each session, we'll be alternating between the mics and the online questions. For feedback on the conference, there will be survey pop-ups at the end of each session for those who are joining online. For those in person, you can access the survey through the QR code that will be on subsequent slides. Please fill out the surveys. We take them very seriously as we plan for the event each year. And for those of you on social media, we encourage you to live tweet today's proceedings. Start by following UHF at UHF HOSP Fund on Twitter, and you'll see a tweet this morning with the conference hashtag UHF Medicaid 22. Finally, I'm going to hope that as you leave today, you'll be wanting more of our educational programming. So please be on the lookout for registration for our October 25th Research Symposium. This is our annual research conference that we do in collaboration with the Greater New York Hospital Association. And each year, the symposium highlights great health services research done in the New York area. If you want to submit an abstract, we just extended the deadline. It's July 29th, and instructions are on our website. It's now my absolute pleasure to introduce Lori Frank, Senior Vice President for Research Policy and Programs at Nyam, again, one of our lead conference sponsors, for a few welcome remarks. Please welcome Lori.
Thank you very much for that. And I'm Lori Frank, Senior Vice President for Research Policy and Programs here at the New York Academy of Medicine. And on behalf of all of my Nyam colleagues, I want to welcome you here today. For those of you joining us online, I encourage you to take a look at our website and see this beautiful building and all of its very unique features, especially our library. And for those of you here in the room, I encourage you to also take a look at those unique features. I know there'll be a great backdrop for the work of the day that's ahead of all of us. My job as welcomer has three traditional elements, and I'm not one to buck tradition. So let me get started with element one, which is to be brief. And I promise you that I will, because there's a wonderful keynote coming up that I'm anxious to get to, and there's a great program ahead. So with that, I'll move quickly to traditional element number two, which is to draw connections. And in this case, this is quite easy to do. As many of you know, the mission of Nyam is to advance public health and health equity. And Nyam has been involved in Medicaid work and Medicaid policy going back more than a decade with Medicaid redesign, more recently with DSRIP implementation and with community health assessment and with evaluation of programs, especially related to mental health and chronic disease. And Nyam has worked with the New York State Department of Health to explore consumer understanding and messaging as part of that work. So our work on Medicaid relevant public health addresses all stages of the lifespan here at Nyam. And as I mentioned, the work focuses on communities for whom Medicaid policy is truly critical. It's that work with and within communities in and around New York and in and around the country that really drew me here, but that's part of the connection. So on to the third and final traditional element of a welcome speech, and that is to discuss the laws of physics. So I will remind you all that there are many different types of energy, and I want to focus on potential energy and kinetic energy. Kinetic energy, as you recall, is the energy of an object in motion, and potential energy is the energy of an object in relation to others. It's worth remembering that with kinetic energy, it can be transferred and it can also be transformed into different types of energy. So I think now you understand why this is a traditional element of welcome speeches, at least for me. I can feel the energy here in the room. We can feel the energy of all of those of you who are joining online. And I am very excited about the transfer of energy that's only possible with a conference like this, and then the transformation of that energy into something more. I would also want to say that potential energy is a privilege and an opportunity, and there's a great deal of potential energy here today in this room and online, and I'm looking forward to the work that all of you will do to share and to advance Medicaid policy to make the lives of New Yorkers better. So, as I said, I'm not one to buck tradition. That first traditional element was brevity. So with that, I again welcome you to our beautiful building, to the day's conference, and I wish you all a day of learning and sharing and wonderful energy. Thank you.
Thank you, Lori, for that wonderful welcome. For those of you who are not already members or fellows of the Academy, I think that was a great advertisement. So go on the website and look. It's 2,000 fellows and members of the Academy. It's a great group to be a part of. It's now my honor to introduce our keynote speaker, New York State's Medicaid Director, Amir Basiri. Amir is a social worker by training, a tireless public servant. After working in the nonprofit sector, he joined our state government 7 years ago, first in the governor's office and then transitioned to the Department of Health in 2019. I've had the privilege of knowing and working with Amir for several years now, and I can personally attest that we are fortunate to have a person of his intellect, dedication, and integrity leading our Medicaid program. So without further ado, Amir Basiri.
Thank you, Dr. Shi, for the very nice welcome remarks, and to Lori and Nyam for jointly hosting this conference with the United Hospital Fund. It is an honor to be here, especially to be here in person. I know the last couple conferences we've had to do virtually, but to be able to see people and see old colleagues is very nice. And so I hope today's conference is that much more meaningful. And I do want to give a special shout out to Dr. Shi, someone I truly respect and admire, and whose disposition, humbleness, and just integrative approach has really emanated throughout the United Hospital Fund and his staff. And you will leave a very long-lasting legacy, Dr. Shi, and it's an honor to be here with you. So what am I here to talk about today in alignment with the conference? Let me figure out how the slides work here. There we go. So I'm here to give the keynote speech, State of the State of Medicaid, really in alignment with what we've been doing to invest in health equity, and specifically as it relates to some of the coverage expansion and program updates that we've recently enacted in the budget, as well as what we envision and plan to do through the 1115 Waiver Amendment. But I also have dedicated some time to something very important, really speaking to what Dr. Shi mentioned in his opening remarks, which is the power of public health insurance programs and what those programs have been able to do to mitigate disruption for consumers throughout the health insurance industry as we've gone through the public health emergency period and experienced changes in the economy, drastic and unpredictable. So starting with my agenda, I want to start with the program overview, talk about what's happened over the last 3 years, how we got here, all of which has fed and led into the 1115 Waiver Amendment, which is not a new amendment. People think it's new, but it's really been something that has been thought about, designed, discussed for a couple of years, and it's really a credit to my predecessor, Brett Friedman. And then I'll get into the PHE and those impacts. But ultimately, a lot of what I'll talk about today is attributable to the work that has happened over the last 3 years. The last two conferences you've heard from Donna Frescatore and Brett Friedman about how the Medicaid program is thinking about health equity. How are we defining it? What are the concepts behind it? Where are the gaps that we see? And what I'm going to talk about today, including the program overview, is really a credit to the foundation and all the initiatives that they laid in place, which I hope to carry out with the rest of the Medicaid team. So Medicaid overall, it's always hard to do an overview slide, but in this context, it's really to demonstrate the commitment that the Medicaid program and the state has had to managed care. And this goes back to the partnership plan, 1997. We initially had less than 1 million people in the Medicaid program that has grown to almost 6 million in managed care today. We still have the partnership plan in effect. All of our managed care programs are practically under this 1115 authority. And what it really demonstrates is the power of that authority and the power of the delivery system of managed care to foster innovation and address things around health equity and coverage expansion. All of that led into very large systematic reform, the 2014 Waiver Amendment, DSRIP, which really fundamentally shifted the way we think about delivering and paying for care, moving towards value-based care, and really laid the infrastructure and groundwork for what we're hoping to build on in this more recent amendment, which takes all of the lessons learned in DSRIP, all of the successes, attempts to scale them under a health equity lens, knowing that we've gone through and are still in a public health emergency period that is having significant effects on access to care and delivery of care. Also interesting to see the growth of the program. I mean, this program, the Medicaid program, is now over $90 billion. It has recently grown by almost 15 billion in the last 2 years. A lot of that is attributable to federal funding infusion, whether it be through enhanced federal matching percentage or the American Rescue Plan investments, but it's also driven by state investments under Governor Hochul's leadership and the legislature's support. We have made significant investments, particularly in the last year that I'll go through, to expand coverage and align benefits. And it's all around the strategy. Everything we've done in this past budget is really demonstrating the long-term commitment and focus we have on health equity and the commitment to continued coverage expansion, all done through this strategic lens of addressing the inequities we see in both the Medicaid program and elsewhere in the public health insurance programs, aligning benefits in terms of coverage and services so that as income changes, people can still maintain continuity of coverage and service as they move across public health insurance product lines. And so I'll highlight a few of the bigger ticket initiatives that we passed this year, but there is a whole host of others. This is the biggest investment in the Medicaid program in this past year that I have seen in my time in state government. And it is truly laying the groundwork to ensure that we can be successful through things like the 1115 and ensuring continuity of care as we go through the public health emergency wind down. First, starting with a big inequity that we wanted to address. The ACA did a wonderful job expanding coverage for single childless adults. And it expanded eligibility for those adults as well, but it did not address a group, very vulnerable group that we refer to as the non-MAGI group, who are also adults, dually eligible, who face different income eligibility requirements. And as they age into Medicare, their eligibility requirements change. So 138% of federal poverty level is what it is for most adults in the program. they age into Medicare, turn 65, the income eligibility drops to 87% of the federal poverty line. That's about $10,000 a year, very low. And what does that mean? That means a lot of people lose coverage and they are required to go into the delivery system, access care without that coverage, spend down their limited resources, then come back to the program. Doesn't make a lot of sense. It's not very equitable. We wanted to address that. And under Governor Hochul's leadership, we did do that this past year. And this will impact about 2,500 people who age into Medicare each month in the program. And we believe that as we get into the public health emergency unwind, which we'll get to later, this will be a very, very important change to mitigate loss of coverage for a very vulnerable population. It also increases the resource limit. It's a statutory increase, so that is a good thing as well. We are hoping to implement this in early January. There are a lot of system complications. We have to work with the districts. So we are eager to get this implemented prior to the unwind and are very excited about this. Coupled with that, we saw that as we start increasing and aligning benefits and smoothing out cliffs in income eligibility, we found opportunities. And one was increasing access to Medicare through the Medicare savings programs. Really a big shout out to Bill Emery on Lisa Sobrana's eligibility team, who really came up with this concept that is somewhat connected to the initiative I just described. But the Medicare savings program is far too complicated. There are 3 different programs, all of which provide different levels of benefits, Medicare benefits, whether it's Part A or Part B, and some co-insurance cost sharing. And we didn't want to have overlap in the income eligibility as we raised up to 138. And we saw an opportunity to both increase the Medicare savings program eligibility, simplify the program, and leverage federal funding, because one of the programs for qualified individuals is all fully federally funded. So we increased the eligibility for qualified individuals from the range of 120 to 135 to 136 or 138 to 186, sorry, which is significant and will help about 100,000 older New Yorkers get access and support for the Medicare program. Relatedly, and not stated enough, is that there is another benefit of this program and the expansion of this program, which is access to, or automatic eligibility, I should say, into the Extra Help Low Income Subsidy Part D program. This reduces seniors' drug and out-of-pocket drug expenses. By expanding this program, these individuals are automatically enrolled in the LIS subsidy, which will help about 66,000 seniors reduce their prescription drug coverage, which is very significant and also has an ancillary benefit to the EPIC program that runs in our public health office. Very monumental effort this year to expand coverage to the undocumented population, starting with those seniors over 65, somewhat in alignment with what we've been doing to really focus on the inequities for older adults in the programs. This will be state-only Medicaid investment. There is no federal authority to receive matching funds on the undocumented population outside of certain Medicaid programs like emergency services. We have designed this in a way to provide the equivalent of what all of our mainstream managed care beneficiaries receive in terms of the benefit structure, the coverage. Over 6 million people get that today. We want to provide that same level of coverage to these undocumented seniors, and we plan to roll this out ideally by 3/1/22, but we are realizing that with all of the benefit changes and expansions and coverage changes, including things coming in 4/1, we think it's probably best we align the date, the implementation dates. So when we do things like transition the pharmacy benefit or add new benefits to the benefit package, that everything happens smoothly at the same time. But we're very excited about this. We think it'll help at least 25,000 older adults who are currently undocumented. And we think this is a great first step to expanding coverage to that population, comprehensive coverage. we could probably have an entire UHF conference on maternal health and advancing maternal health. I mean, it is such a complicated and important issue. And I think everyone is in agreement that the outcomes that we have, especially the outcomes for New Yorkers, is not good enough. It's not something we should be proud of or acceptable of. And the Medicaid program is taking on a few different areas to really advance and prioritize maternal health. But this is a priority of the entire Department of Health, including Commissioner Dr. Bassett. And we have an internal working group across DOH and with other state agencies to really tackle this in a meaningful way. Starting with something we recently released, the updated perinatal standards. We just put this out via guidance. There's a screenshot there. It doesn't even capture half of the areas and sections of updated clinical standards based on national evidence-based practices, as well as expectations that we have of our health plan partners and the providers in their network. And there's a distinct health equity focus on these standards to eliminate racial biases and implicit bias that we are very happy with and really trying to enforce down to the plans and providers. To support those efforts and those updated standards, we are making strategic investments in maternal health, really targeted around access, quality, and experience of care, something we don't talk about enough, experience of care, to ensure that we are doing everything we can from the Medicaid standpoint to offer opportunities for better maternal health outcomes and better engagement and coordination across providers. We're adding new services that are eligible for reimbursement, nutrition services, registered dietitians that treat pregnant women will be eligible for reimbursement. We are adding that. We are adding care coordination services and allowing for community health workers and family navigators to be reimbursed for serving maternal health patients outside of traditional healthcare settings. We are increasing reimbursement rates for midwifery services. The evidence is there. We know that the investment is worthwhile, and we want midwifery to be reimbursed at similar levels as other practitioners, like nurse practitioners. And that is something that is all happening simultaneously. To move towards value-based payment models, we're looking at leveraging the state-directed payment authority, which is a managed care authority, to invest dollars into quality-based outcomes and a value-based payment arrangement around labor and delivery hospitals, really focused on reducing poor maternal health outcomes, cesarean deliveries, NICU, where a lot of the spending occurs and a lot of the poor outcomes occur. There's a lot of value in doing this, and it's very challenging to do this. And we're trying to be extremely thoughtful, working across state government to identify the right interventions, the right quality measures, some of which don't exist today, to meaningfully demonstrate that we are making progress in improving these outcomes for 50% of the births that occur in New York State. Last, but certainly not least, is the expansion of postpartum coverage across Medicaid, Child Health Plus, and EP from 60 days to 12 months. This is something you've seen other states doing. Several other states are moving in this direction. We're very, very excited about this. It is part of the coverage expansion strategy, and we will be putting out a state plan amendment in the near future to show how we plan to go forward in this respect. But this will help a significant number of women, including undocumented women who don't receive any postpartum care coverage under the Medicaid program after this period. In alignment with what I mentioned earlier of aligning benefits and services across programs, we are adding and expanding the Essential Plan and Child Health Plus. In collaboration with the New York State Health Marketplace team and Danielle Holohan and her team, we've really tried to make Medicaid sort of the benchmark for the services we offer and the coverage we offer as people move in and out of product lines. In the Essential Plan, there is no coverage for community-based long-term care services. There are members of the essential plan who access those services in the fee-for-service program. Those are what we refer to as the ALIESA population, those below 138% FPL. But we believe it's important, especially where we're going, to add this benefit package to the essential plan. We're going to start with those that are currently receiving the services today. That's sort of the phase one. That will happen a lot sooner. The infrastructure is there. But phase two by 2025 will have all community-based long-term services and supports from personal care to social adult daycare, home health care, available to all essential plan members, and really round out that benefit package to be at or equivalent to the Medicaid program. Expanding Child Health Plus to add critical mental health services, residential youth programs, ACT teams, other very important behavioral health investments, working with our OMH and OASIS partners, so that Child Health Plus, children and the families in Child Health Plus have the same mental health services as do individuals in the Medicaid program. Very, very important effort that will be supported by a premium elimination for some families in Child Health Plus that pay the $9 monthly premium, which is really a deterrent to continuity of coverage for these families. This will preserve over 160,000 families from losing coverage in CHIP. Very big deal, very important, and something that we think is going to have a very strong impact in mitigating the PHE unwind. There are other things we're doing. They're subject to federal approval, postpartum coverage expansion being one of them. But another, thing that we're really pursuing is preserving member choice in the essential plan. Today, when a woman is deemed pregnant in the essential plan, she is required to go and come out of the essential plan and enroll in Medicaid. And part of that is because our Medicaid eligibility is for pregnant persons is higher than that of the essential plan. It goes up to 223. But not all people want to leave their essential plan package or premium. They're happy where they are. All we want to do is give them the option to stay there. And I think it's in alignment with where CMS wants to go and the federal government is generally with preserving member choice. And it's something we really believe we will get support for and will be a nice member empowerment option in the event people do not want to change products, given that these products are very similar. Other investments that we are making this year, I'll go over these quickly, but essentially we are changing the global cap, which is our measure of state-only Medicaid funding growth each and every year. Historically, it's been tied to the medical component of the consumer price index, which is about 3%. The 10-year rolling average is about 3%. Over time, we have realized that that's not necessarily reflective of the population we're serving. And as the program has grown to the scale that it has, over almost 2 million people have been added to the program, there's a recognition that that growth rate should be adjusted. And we are using the Office of the Actuary, CMS Office of the Actuary, Medicaid-specific growth rate projection, which factors in more things than does the CPI, things like enrollment, utilization, case mix acuity, to enable more spending in the Medicaid program over the next 3 years. And this change will allow us to spend up to an additional $6 billion over the next 3 years, which is very important and a strong recognition from the governor and the legislature that additional Medicaid spending is needed. We're doing an across-the-board rate increase, 1%, all providers, intended to recognize some of the challenges related to workforce, labor delivery costs, inflation. We know it's not enough, but this is going to be coupled with the elimination of a 1.5% payment reduction, in addition to all the other rate increases that we're instituting, including the investment in primary care. We have not increased physician reimbursement rates in fee-for-service since 2009. They were historically benchmarked to 60% of Medicare, which is low, and they haven't been changed. And we're making a sizable over $20 million investment in those reimbursement rates to benchmark them to 70% of Medicare, which we think will continue our priority to promote and advanced primary care. Lastly, I'll touch on this a little bit, but we want to be more responsive, more member-centric in everything that we're doing. And things from our social media strategy that Marcy Natal is leading to how we engage with our members. And we're developing, as part of the federal interoperability rule, patient platforms, patient tools to access their own data. And we're developing it in such a way that they don't have to use a state application. It will be, the API will connect to other eHealth, mHealth applications, but so the members can see their historical fee-for-service data, claims, lab results, all on their smartphones, which is obviously the direction that healthcare has been going and will continue to go. So we're very excited about that too. Shifting gears a little bit, but all of these things sort of feed into the larger 1115 health equity strategy. And as I mentioned earlier, this is not necessarily something we just thought of. It builds upon years of thoughtful design, building off of initially the DSRIP waiver and the successes of that waiver to the what we submitted to CMS that was rejected under the Trump administration, which was DSRIP 2.0 concept, which was then reframed after New York was, disproportionately impacted by the public health emergency, which, we are still feeling the effects of, and really exacerbated and highlighted some of the health inequities and health disparities that already existed, given what was going on during the pandemic. And I really do want to credit my predecessor and friend, Brett Friedman, for his effort in terms of getting this waiver to where it is, both in terms of the vision and the stakeholder engagement. I mean, Brett spent about 2 solid years working with all stakeholders, internal, external, Office of Public Health, Office of Minority Health and Health Disparities, Office of Quality and Patient Safety, all of the community advocate groups. I can't think of someone he did not engage with and get feedback on. And it really speaks to the comments that we've gotten, which I will talk about, and the support we have for this waiver, because it really is designed in such a way that incorporates a lot of the feedback you all have and have submitted via the public transparency process. It is built under our existing 1115 authority that I mentioned before, formerly known as the Partnership Plan, the MRT waiver, been in effect since '97. And was recently renewed through 2027. Very broad-based goals, really highlighting what we can do under the managed care delivery system in terms of innovation. We have all of our managed care programs under this authority. All the innovation we've achieved to date through DSRIP and thereafter is due to this flexibility. And we really want to take that to another level through this new 1115. And as I've mentioned, DSRIP had a lot of successes and a lot of lessons learned. The shift to value-based payment objectively was successful. We had over 80%. We met every goal in terms of level 1, level 2, upside downside risk targets that we agreed upon with the federal government. And we were able to really move and develop the infrastructure to engage CBOs into VBP, bring together the social care providers with healthcare providers, and really develop some promising practices and new ways to work together. It didn't happen scale in terms statewide, but really what this new waiver is aiming to do is take all of the successes, build upon the lessons learned, and really continue that movement towards integrating health, behavioral, and social care with a distinct focus on building CBO capacity to meaningfully participate in VBP. There were things that we know and acknowledge need to get better. While we did a great job on moving to VBP, not all populations, meaningfully participated in VBP. Some of that was due to overlapping regions, attribution, the focus on primary care as opposed to primary and behavioral health care. But we are hoping through this waiver and through the investment in advancing VBP to really target and design more population-specific arrangements that are tied to the health equity needs of those populations through the meaningful investment we're making, both in the structure, the design, the heroes and SDHNs, as well as the $7 billion in VBP specifically. You've seen this slide before, I'm sure. So I will go over it relatively quickly with the details thereafter, but there are 4 primary goals of this waiver. The first being the largest investment on health equity focused system redesign. There's a lot underneath this goal, and that is necessary to achieve this goal, starting with our regional planning entities known as the heroes, the health equity regional planning entities, going down to the social determinant of health networks, the networks of CBOs that are going to be working with our plan partners to engage in VBP and engage CBOs addressing these health equity needs in VBP. And then going on to the VBP investments and incentives through those $7 billion. There's also the focus on criminal justice involved populations under this goal that is built and informed by the 2018 waiver that was rejected or withdrawn, I should say, by the Trump administration. But that is something we feel is absolutely critical and a population that has not been engaged meaningfully in the Medicaid program and been set up to transition into the community successfully. We're doubling down on supportive housing. We know supportive housing works. We know it works when it's targeted and when it's supported by wraparound services. We are making a meaningful investment here, and we are doing it knowing that there is a solid return on investment. And so we know this works. The third goal, something that is impacting all of us, not just in healthcare, but all areas of the economy, is workforce. So we are making a sizable investment and commitment to funding workforce. $3 billion of this waiver will go towards that. It will ensure we have adequate training, standardized training, more development of career advancement opportunities, more training on overcoming racial and implicit bias. And this is something we have heard overwhelming support of through your comments. And so we remain committed to this as part of an underlying waiver goal. And then last, digital health and telehealth infrastructure. I mean, telehealth, nobody needs to comment on how impactful that has been and how it has changed the delivery system, especially as we've gone through the public health emergency. There is not a ton of money in here, but the money that we do have in here is really intended to reach those providers that can't meaningfully participate in telehealth, don't have the cash flow, the infrastructure to make those investments, to have the data systems that are interoperable with the EHRs and such. And so we're going to be making direct investments in that area. I'll go through this a little bit in more detail on each goal. Really, everything starts with the health equity regional organizations. And a big part of this is driven by, we are trying to change the way care is delivered. We are trying to bring more providers, different providers together. And we don't actually know the details of the health equity needs of our members. And this is something that has frustrated me, it's frustrated everyone before me, and it's been highlighted in prior presentations. We don't even have full scope of race and ethnicity data for over half of our members. We are now trying to get more social determinant of health and health equity related data without even having that information. So the huge focus of this waiver and the lasting legacy of this waiver is going to be enriching our member data to really understand who we're trying to serve and how we should best serve them. Our plan partners are going to be critical in that. Social determinant of health networks are going to be critical in that, as are the heroes, who are really designed to be these regional planning entities to both outline, identify, and chart the health equity needs of each geographic region. They are going to be hubs for data and collaboration. And this is really building on what we know worked in DISRIP, which was bringing different providers in the room and working together to solve very difficult, challenging problems. There is a distinct focus and need to focus on social determinants of health and health equity, and the heroes are going to be critical in achieving that goal. Supported by that, and likely to be a member of these heroes, are the social determinant of health networks, the networks of CBOs. We have some of them that have really advanced since DISRIP in different regions of the state. Some are coming together. We want to really invest in that infrastructure through this waiver, invest in the data systems, ensuring that data can be transmitted, integrated, interoperable with our Medicaid data, with EHRs, et cetera, and really bring together all of the social care providers who haven't traditionally participated in VBP or the healthcare delivery system generally, to get their foot in the door and demonstrate the value add they have in improving health and health equity needs of the members. All that is going to be facilitated by the $7 billion investment in advanced VBP. This will be supported through our VBP roadmap, which will evolve as we go through this process. And it is very much going to be tied towards serving harder to reach populations and those that have not participated in VBP up to this point, including the behavioral health population, the criminally justice involved population, and others like that, chronically homeless. And as I mentioned, we are reinvigorating the 30-day early activation of Medicaid for individuals who are being discharged from incarceration. We've gotten a lot of comments about this. People want 60 days, 90 days. We know 30 days can be approved. So I think we're probably going to stick with that, but this is just the first step. I mean, we really believe this is absolutely critical to ensuring transition to the community. How can one be successful in leaving institutional settings without that proper care management and transition support? This will enable us to do that with our plan partners and get these people the proper supports and they need when leaving incarceration, and medications and other important care management functions. Doubling down on supportive housing, as I said, and really what we've done here, thanks to Emily Engel on our team, who really has her footprint all over this waiver, but really was instrumental in our initial MRT1 supportive housing waiver, which demonstrated how impactful supportive housing can actually be, especially for high utilizers of healthcare services and in the Medicaid program, is we are trying to both continue those investments, but also strengthen the transitional supports when someone is in institutional setting. We can't get FFP by delivering those services in those institutional settings. It's a violation of the HDBS rule, and there's other difficulties with doing that. So what we're doing is building the bridge, those transitional services, whether it's medical respite, street medicine, other transitional supports to get someone out of the institutional setting with the proper supports and safely placed in stable housing, supported then by a continuation of those care management and support services. It's very important, and we think this is something we really will demonstrate to CMS that we are delivering on the initial success of our initial MRT1 supportive housing waiver. The workforce, the $3 billion is being split between two buckets. One of it is focused on more institutional providers, hospitals, nursing homes, really structured around advanced training, quality improvement, ensuring they have adequate resources to surge and flex when needed. And the remaining half, the 1.5 billion, is really going to build capacity in the system through training, through career advancement. We want to fund the WIOs, the workforce innovation offices. We want to do a lot of the things we know there is limited funding to do and are absolutely critical to do to make healthcare and working in healthcare an opportunity to advance in your career, starting from peer support specialist, community health worker, home health aide, all being able to advance through the system and deliver services in different settings of care. Equitable access to telehealth. I'll close here with the last goal. We really do want to get meaningful engagement in telehealth for those providers that can't currently participate. And we're thinking differently around here. And there's been really, really awesome ideas that we've heard from you all, including things like putting telehealth kiosks in homeless shelters, developing specialty care virtual care models, all sorts of wonderful ideas that we're really looking to use this money to fund. And so where are we now? We are finalizing the public comment process. There have been ample opportunities, as I mentioned, up to this point for public comment, but formally through the CMS process, we have gone and held 2 virtual hearings. We have received tons of written comments. As you'll see, over 400 organizations, or not over 400, almost 400 organizations have submitted some form of a written or verbal comment, and that is 1,800 comments. That is unbelievable and incredible when you think about it, especially most of these comments are extremely supportive of the underlying goals of the waiver. I really wanted to let this group know that not only do we appreciate the ongoing feedback, but it has almost reaffirmed the approach that we've taken, and that there's nothing that anyone has said that really necessitates a structural or foundational change to how we have developed this waiver and the underlying goals of the waiver. We are going to incorporate, good constructive feedback that we've gotten. I won't go through everything, but we have an army of people working on these comments across state government, depending on their subject matter expertise in the Office of Mental Health, our Office of Quality and Patient Safety, our team. And for those that are watching this, please get back to work. But we are really trying to get through this as quickly as possible, because we know that there is a lot of interest in knowing what the final application is. And we also have a very, very ambitious timeline, which I'll talk about in a minute. But we looked at the comments and we said, how can we digest this for people? And we are going to put something on the website as part of the CMS transparency process, and just generally to let you know, what are people saying? We've categorized things into 20 distinct areas, and the size of the font is demonstrating, the volume of comments in that specific area. So you'll see, by far and away, the largest volume of comments we've received is on the HERO and SDHN concepts. There have been arguments on various sides of any issue you want to say, whether it's the number of regions, their role, what they're responsible for doing, their funding, et cetera. And I think generally we are trying to clarify the roles of the HEROs, let people know that there's not a limitation in the types of providers that can participate in a HERO. There's not a limitation as to who can lead the HERO. And to the extent there are the need for sub-regions or micro regions, we will consider that through the procurement process to identify the HEROs. But generally, everybody is supportive of what the HEROs are trying to do. And there has been a focus on more so what the SDHN role is and the funding for the SDHNs in the waiver, which I'll talk about in a minute. Others are workforce, second largest comment area, mostly reaffirming, the commitment to workforce and not to reduce any funding in that area, which we completely agree with. Child and maternal health, reproductive health as well, but children's and maternal health has been a huge, huge priority of the comments we've received, and we do want to clarify some things to incorporate that into the final waiver application. Most of the other aspects, including criminal justice, have been overwhelmingly supportive, and we will be sharing more information on that in the coming days. So I thought it'd be good to do a sampling of what we're hearing. And this is really hard because, as I mentioned, there's literally comments on both sides of the equation, but we've tried to summarize a lot of what we heard consistently, starting with the emphasis and importance of the workforce funding. It is something we see every day. We're seeing it across the delivery system across the country. We recognize how important this is. Recruitment and retention is absolutely critical to achieving the goals of this waiver, and we are not wavering on the $3 billion commitment we have towards workforce in the waiver. There has been a big ask in terms of establishing more funding and long-term sustainability for the social determinant of health networks. There's a variability as to where the networks of CBOs are throughout the regions of the state. Some are well established, some have been outgrowths of DSRIP, some have come together on their own. You'll probably hear from some today. And essentially not everyone is as sophisticated and there in terms of organizing and infrastructure. So there's been a key ask for that, specifically as it relates to the data infrastructure and the capturing of this social determinant of health referral data and the health equity data which we expect and will put requirements around data sharing, interoperability, and essentially structure to a currently unstructured data set so that we can really use this and use the power of this to incorporate it into long-term payment reform of the Medicaid program. We want this data to be able to risk adjust our plan premiums, to adequately pay them and incentivize them for caring for very expensive or harder to serve populations. This is going to be a very long, hard, and important undertaking through this waiver that we really fundamentally believe has to sustain in changing the way we deliver care. So commitment to the SDHNs is definitely something that is resonating with us. And I expect there will be some clarification in that area and possibly some additional funding. Some of the more sophisticated VBP providers and integrated health networks who have used DISRIP as a jumpstart to really innovate well, far in advance of where the state is, have indicated and demonstrated that they don't want, the HERO process, the waiver process, government to get in the way of these innovative arrangements that are either in place today or set to be in place today, all of which do aim to address the underlying health equity goals we have in the Medicaid program. We agree with that. We don't think it's widespread because of how difficult and challenging this type of work is, but we are not intending to inhibit the progress that is occurring in the market. We are all for VBP, an innovative VBP for harder to serve populations. And so we are going to clarify that as part of this waiver and create opportunities to enable that work to continue so long as it is in alignment with the goals of the waiver. A renewed emphasis on reproductive health and additional community-based programs and violence prevention. We saw a lot of success on a micro level in DISRIP, in the PPS work in these areas, particularly in Albany on community-based violence prevention, centering pregnancy pilot, first 1,000 days. I mean, a lot of really great work was done in terms of piloting these efforts. And we believe that those should be prioritized and scaled as part of the HERO regions in terms of what their priorities are and the providers that are part of those regions. And so that is something that has resonated with us, and we will clarify and incorporate into the application. And ultimately, the commitment to innovative design for interventions for specific populations, which is what we are trying to do with VBP, recognizing this as a managed care delivery system and a managed care waiver. So not all populations are in managed care. They're not all mandated to be in managed care. However, there are people in those populations at a smaller degree who are choosing to be voluntarily in managed care. And we really see this as an opportunity. Again, going back to the history New York has with the managed care delivery system, we can really demonstrate whether or not managed care can offer innovative design, quality improvement, better outcomes for those populations that are in managed care. And we are planning to use this vehicle and this waiver as an opportunity to innovate in those areas. So we're very excited about that. It's going to be limited to the managed care population, but it doesn't mean we won't be able to demonstrate, what can work in different ways. So the timeline, very ambitious timeline. It says August, we'll be done with the review of public comments. We plan to do that. We are on track. As I said, there's an army of people working day and night on addressing your comments. Our target date for formal submission of the amendment to CMS is September 1st. And then selfishly, I am not going to move this date because I'm getting married that weekend and I plan to get married that weekend. Thank you. After submission, there will be a federal public comment period. There will be additional, you don't like what we've done, you'll have the opportunity to let the federal government know. And ultimately, we want to get into negotiations with CMS. The negotiations are going to be very technical, and a lot of the concepts we have will be better defined in terms of funds flow and design based on the feedback we get from CMS and the terms and conditions they hold us to in what we are trying to achieve from a quality standpoint, evaluation standpoint through this waiver. We're targeting January 1st. As I mentioned before, the engagement effort that Brett had taken included CMS and our federal partners. So they are aware of everything we've done, including they have given feedback to the concept paper. They are in support of the waiver, the concepts, everything aligns with the federal priorities. So we do have hope that we will be able to execute this quickly. Will it happen on January 1st? I hope so. But if not, we do expect a faster turnaround time than is traditional with these negotiations. But there is a chance, and it's likely that we don't get this in effect in January, which will allow us more time to really formalize and finalize the details, but we are still targeting it. I want to transition to something that is very important to all of us and very important, not just to the managed care program, but the entire Medicaid and all public health insurance programs, which is the public health emergency. Just to level set on the COVID public health emergency, it was declared under Section 319 of the Public Health Service Act by the Secretary of Health and Human Services. It is currently still in effect. It was recently renewed as of July 15th, meaning that it runs through September. We have strong confidence, and as do our federal partners, that it will be extended again through the calendar year, which is a good thing for many respects. There are some downsides to that. From my standpoint, one thing I have seen in the 3 years we've been in this period is it has confounded our data. We have not been able to move people out of the eligibility groups that they were in when the public health emergency took effect, meaning that numbers are not necessarily reflective of where they will be when we wind down activities. And things may look larger or smaller than they actually are in terms of enrollment and utilization. The other confounding impact by having it extend through the calendar year is that we will be in the midst of an open enrollment period where people are signing up and getting access to health insurance, which will complicate things given that we have most of our enrollment through the New York State of Health. And we have acknowledged that with CMS. So we are hopeful that it will be extended beyond 1/1/23. And if not, CMS has acknowledged and supported, our efforts to possibly get a waiver to get an extra short period of time. Fundamentally, I think what has really been wonderful about going through this process is that every stakeholder, every partner, every actor involved in this, in the public health emergency is completely aligned with what we're trying to do through the unwind, starting with our partners at CMS and Health and Human Services, who we talk to regularly and who want to make sure New York has what it needs to be prepared. Going down to the state level through the governor and the legislature and the financial support from the Division of Budget to ensure that the New York State of Health and the Medicaid program has the resources it needs to educate consumers, to make technological efficiencies, to make this as seamless as possible for the 8 million people that will be impacted. And all the way down to our local district partners and the community advocates who we speak to regularly, and we are all in alignment with our underlying goal and messaging. So that has really been a pleasure to see. You don't see that in healthcare that often. In addition, we've benefited from some federal funding that has come with this public health emergency authority through the FMAP that we're getting in Medicaid, and also through enhanced ARPA subsidies, which is reducing commercial insurance or individual insurance and providing premium assistance up to $100 a month for 100,000 New Yorkers, which is significant, really reducing the cost of coverage for those populations. And regulatorily, we have adopted 100+ flexibilities across the Department of Health alone, varying from regulatory changes to payment flexibility to telehealth flexibility. A lot of this is going to be challenging to unwind, but we are committed to working with the stakeholders to ensure that whatever we do, people are informed and their recommendations are incorporated into how we unwind these authorities. As Tony and Dr. Shi mentioned in the beginning, you know, public health insurance has really been a lifeline for millions and millions of New Yorkers over the last 2 years. And it's really, the numbers tell the story. We have over almost 9 million people in some form of public health insurance, whether it's Child Health Plus, Medicaid, or the Essential Plan. The number has grown significantly over the last 2 years, and we're approaching about half of the state's population being in some form of public health insurance, demonstrating the gravity and how seriously and committed we are to ensuring a smooth unwind. When that notification comes down from Health and Human Services, we are prepared. And it's a big thanks to a lot of the work we've been doing with our local partners. Managed care has been the primary driver of the growth in enrollment. We've increased by over 1 million people. A lot of it, again, demonstrates the value of the managed care delivery system as being the root and foundation of the Medicaid program and what we can do in times of uncertainty and pandemic. And we've adopted a lot of flexibilities. We meet with the health plans monthly to prepare for this unwind. The partnership is strong. We need their help. When 3 years goes by and people have not, half of them have not had their eligibility renewed ever, and the other half haven't had it renewed in 3 years or 2 years, over 2 years, there are a lot of things change. People move, conditions change. People need more services. Some people need less services. It's up to the local and plan partners to really work with us to make sure we know what's going on and how to better reach people. And I'll talk about, I'm going to gloss over this next slide and talk about a little bit more about what we're doing and why it has taken so much time in planning. And a big, huge shout out to the New York State of Health team, who are our partners, Danielle Holohan, Sonia Shekar, Lisa Sabrana, and our Medicaid eligibility team. They work on this day and night. It is unbelievable the commitment they have, which really makes my job a lot easier, honestly, to have confidence to know that we are doing every single thing in our power to ensure we're prepared and that anyone who is eligible for any form of public health insurance will keep that form of insurance. And that is a commitment we have and are working very hand in glove with the local partners and community advocates to ensure. We're updating consumer notices. We have done some easements in eligibility through the New York State of Health to make it easier for people to renew. We're updating our welfare management system to incorporate some of the eligibility changes I mentioned at the beginning of the presentation to really ensure continuity of coverage. And those will help mitigate potential disruption for members, especially some of our older, more vulnerable members. And we have beefed up the New York State of Health call center and also work closely with the local districts to get them prepared for volume changes, anticipated changes, and getting the proper staffing that they need. We have a consumer campaign and a public education campaign. You may have seen things on the subway. You may see ads. We are going to continue that. We need everyone's support to make sure everyone has the information they need and is not going to show up at some healthcare provider and realize that they don't have coverage. That is the last thing any of us want. And I know that there's a commitment across the delivery system to ensure that doesn't happen. We do have a commitment to transparency during the unwind, and it is funny that I have a slide on a commitment to transparency, to showing data you can't see. But really, the takeaway here is that we're working on a lot of different things. And this is really driven by the feedback we've gotten from our consumer advocacy partners who have demonstrated that it is very important, and we agree that we need your help through this process. We want everyone informed as to how this is progressing as we go through this process. It's absolutely critical we hear your feedback. What's not working, what is working. Without that, we can't be nimble, we can't make changes, we can't address this in the way that it needs to be addressed. We are preparing some public standard reporting that will highlight utilization and changes in utilization and coverage across our eligibility systems. It's not ready yet, but it will be ready by the time we are faced and ready to go forward with the unwind. I want to close with just reiterating, what we're doing and what we would appreciate everyone reinforce, whether you're a health plan, whether you're a provider, whether you're a local district, whether you're an advocate. We have taken a lot of different measures through ad campaigns. We've developed toolkits, which are available on the New York State of Health and on the Medicaid landing page. Those toolkits include messaging, communication. Our plan partners are also using that messaging communication. We have call centers available that we can direct people to. We have enabled opt-in text messaging. We have seen very strong response rates from that, especially in the marketplace. It's still an opt-in, but we're taking advantage of every authority we have. And any reiteration of that is going to be very critical to our success. And we need your help and openness as to how things are going when we get to this point. Last but not least, stakeholder collaboration. We meet with the plans regularly. We meet with the local districts regularly. We meet with the consumer advocates regularly. We want to bring those conversations together as we get more information on the timing of this unwind. And we plan to do so. And we also plan after it goes live over the 14-month process to have regular check-ins to hear from everybody as to how we're doing and if things are going as we hope they will. So with that, I thank you for the opportunity and look forward to answering any questions. Alex.
Hi, thank you very much. I'm a social worker who's worked with older adults her whole career. So it's nice to see a social worker giving the keynote today. One concern which struck me when you were talking, and even at the beginning, Dr. Shi, when you mentioned about the evaluation, some people, including myself, and I'm a proud senior myself, especially older adults, may not have access to a lot of the technology, and not only don't have access, but can't afford. They're low income, and so they may be on Medicaid, but they also can't afford access to technology. So I just hope that provisions will be made. I'm sure they will. I wonder if you could talk a little bit about that for the portions of the population who don't have access and who may not soon even be able to get access, so that they're not left behind in any of these innovations and efforts that are being made.
That's a very good question and something I didn't speak to enough, but you are right that those things are taking place. We have a lot of local partners, community assisters who are actually canvassing these communities as our partners in the local districts and elsewhere. But we have very large programs to get at this exact issue. It's not perfect, not everyone is at their door when you show up. Not everyone picks up the phone when you call, but there's definitely a commitment, and we have added resources to do that. The woman actually sitting in front of you, Lisa Sabrina, who runs our Division of Eligibility and Marketplace Integration, runs those programs and really can talk to you in depth about the various things going on. But it is something we're very concerned about. Those are the hardest to reach. Those are the ones we're worried about, and we need help. We can do what we can do, but as the state, we don't have our eyes and ears on the ground in the way that you all do. So we do need help with that, and would appreciate, any ideas you have that we haven't employed already. Sure. Yes, go ahead.
Good morning. My name is Patricia Hernandez, and I'm from the Corporation for Supportive Housing. I appreciate the intentionality of calling out housing and its importance of housing. And of course, as we all know, housing is health. Can't have health without stable housing. One thing that concerns me a bit, and I was wondering if you can address it, is that there is no lack of referrals to CBOs around housing. There's lack of housing. So how do you plan to address that, or do you have any other thoughts? I've seen other states kind of invest more in the actual subsidies around housing, and I just wanted to hear your thoughts around that.
Absolutely. So, initially when we developed the concept paper, which initially asked for $17 billion, and we were told by CMS to sort of scale it back a little bit. We had wanted to go further with housing. We had wanted to invest in room and board, even beyond the tenancy supports, first, last, security, rental application assistance, those aspects. We wanted to think about, how can we leverage the Medicaid dollar even further? And it was something that I think CMS reaffirmed their position on, what is in place today from an authority standpoint is what is in place today. And there was no intention of that necessarily changing. But the value of VBP and thinking about premium as opposed to an actual payment for a service is it blends together a lot of things, and managed care plans can be a lot more innovative than we can be in terms of direct support. Those aspects you're describing are not changing. Those are going to be part of the supportive housing strategy, the tenancy supports, rental assistance. But we don't necessarily think it's the best use of Medicaid money to invest in the capital infrastructure. We need support from the various housing funding programs there are, both federal, city, local. And that's really what we are hoping that the heroes bring together. I mean, a lot of people have expressed concerns that the heroes with respect to housing is duplicative of the CCRCs, but it's really complicated. And both the solutions and investments are stratified and braided from local, city to state levels and federal levels, that there is actually a value add, in our opinion, to have the heroes identify the programs that are in place, the gaps that exist, and what programs could be brought together to create exactly what you referenced, which is access to more housing, which is a fundamental problem. No one's going to disagree with that. And I don't think it's specific to New York, but you're absolutely right. And while we don't have, billions of dollars to build new supportive housing, we certainly will continue to work with the home of community-based renewal and our other state agency partners to leverage as much federal and state dollars as we can to build that access.
Thank you.
Sure, good question. On to the online question.
Thank you. Can you please speak more to the state's intention to issue a competitive procurement for a statewide IT social needs referral and data platform?
Yes, and good question. I think that we are actually rethinking this pretty strongly. And really, it's due to some of the feedback we've gotten from the public comments, and also, trying to realize and be realistic about core competency from the state standpoint. We don't want procurements can take a long time. We know that there's a lot of great work happening on the ground today. These platforms exist, these tools exist. Some are in the midst of its innovation already, embedding these platforms into EHRs, which creates that natural feedback loop and connects to the digital IT infrastructure of the shiny. And so we are thinking that we probably are not going to issue a procurement for a single statewide tool, but rather put in place the technical requirements, the guidelines, what we expect, the interoperability requirements, and fund the infrastructure through the other aspects of the waiver to really ensure the consistency and structure to the data, information flow to the data, and so that we can nimbly provide aggregate state level data while we can require our downstream partners to put things out at the regional and local levels. So, the procurement is probably going to come out of the final concept paper. We are already procuring the heroes, the SEHNs, We don't need to be in procurements for the 5 years that we're in this waiver period. Our goal is to see the outcomes of these investments as quickly as possible without disrupting what's already happening in the ground. And the market's already innovating. The market is always ahead of the state. And so we need to work with the market, and we will do that with respect to the social determinant of health referral and IT platform. Online.
Hi, Katie Ponica-Worms. I'm a pediatrician and senior director of pediatrics at New York City Health and Hospitals. I see one of my partners here, so you're about to get 2 questions around pediatrics and early childhood.
Awesome.
I was really encouraged to see child and maternal health in that word cloud is kind of the 3rd largest, and really, hopeful that you were commenting on how that seems to be something you want to move into the 1115 waiver. I also heard you mention the first 1,000 days and potentially that being prioritized and scaled, and potentially there being statewide language around that being included in the heroes. I was wondering if you can elaborate out that any more at this time.
I pretty much said it's sort of where we are right now, but I will tell you that the state and the Medicaid program, we are so lucky to have Dr. Doug Fish, who is our medical director and who knows and cares more about these issues deeply and has advanced first 1,000 days, the INC grant, our updated perinatal standards, all those things. And so I know he's working on it and thinking about it deeply with our maternal health team and also our partners at OMH, who have a very big focus in improving access to children's behavioral health services and workforce investments in those areas as well. I don't know that we have a clear-cut strategy that will be in the final waiver application, other than noting that it's going to be a very large priority and something we expect and would be more than happy to move the needle on in terms of quality and outcomes as part of the final waiver application.
I didn't recognize Katie with her mask on. Similar, but I'll just kind of add my question to Katie's in support. Dr. Maya Castillo, I'm a pediatrician. I'm pediatric medical director at Health First. And I feel like part of our job as pediatricians is to constantly point out that those low cost, low utilization children who are exposed to the adverse social determinants of health and adverse childhood experiences very quickly become our very high cost, high morbidity population who are in our incarcerated population, our behavioral health population. And so my question relatedly was, has there been discussion about earmarking a specific percentage of the waiver money to support families rather than being tempted to put it all towards our current high cost population, really that preventative strategy to prevent those kids from moving into that group?
Yeah, thanks, Maya. So the comment resonates. What I would say is this: there's no designated pot of money. We're not splitting the $7 billion for VBP and designated pots, at least not at this time. We can get there. But what I would say is, when you think about things that we've accomplished since DSRIP in terms of better, innovative, preventive care for children, I think of the Healthy Homes pilot that I think we are working with several plans on it, but effectively target-based interventions for children at risk or suffering from high rates of asthma to avoid hospitalization, and couple that with investments in home remediation and energy remediation, thanks to our partners at NYSERDA. We are also working in that part of that pilot to bring in-home based asthma services to really provide the education outreach to families. And those are the types of things I could see being prioritized through the $7 billion of VBP investments. First, starting with the priority on preventative care, child and reproductive health care as part of the regional plan, which will drive down those incentives and goals so that those dollars go in that area. It very well could be likely that we set target allocations. We're just not there yet. But it's definitely a big focus. We've seen a lot of successes from initiatives you're talking about, preventative based, in-home based for children. And honestly, that's the best investment we can make. And we recognize that. And so we want to scale what has worked, even if it has been at smaller scale, including this Healthy Homes pilot. And I think we are going to prioritize, there will be a key set of priorities in an updated value-based payment roadmap that will certainly outline our goals and objectives from access and quality standpoint. We're just not setting funding targets at, right now. But thank you for the question. Online? Okay, go ahead.
Hi, my name is Vanessa Wade. I'm with Salient Management Company. We were recently involved in an effort of helping the department dissect the waiver with doing a data fit gap analysis of data needs to support the implementation. So data is on my mind today. And earlier in your presentation, I think you had mentioned some of the limitations around Medicaid members' demographic information, particularly race and ethnicity. So just kind of wondering, like, what's on your mind for improvements there? And then next step of provider demographic, right? To kind of help build that patient provider trusted relationship. So if someone specifically wants a person like them, a provider, like them, that they would have that information readily available to make those choices.
Thank you for the question. Interesting comment. And data is always on my mind. So we can talk anytime after this, but there's a bigger strategy in terms of our Medicaid enterprise, right? So how the pipes are set, where the pipes are coming from. And then there's ultimately enrichment of our existing encounter data. So we're working on both simultaneously. They have corresponding effects. And there's various ideas around how we can enrich that data because, there's ways that we're currently looking at adding secondary data sources, census data, other cloud-based data to suggest information or more informative information about our demographics. But all the data sources are always on different time periods and not as reliable as others. And so we don't want to be necessarily suggestive when we know we can get this information ourselves. Some of the ideas we're thinking about outside of using digital health and IT and the shiny in particular, in the event providers capture this information upon routine well visits, or we have more access to CVOs to the shiny who can report this information through the information health network, is the use of community health workers and other forms of workforce who have a much more trusted relationship with their communities, who understand the hesitations and needs and other implicit reactions that people have when reporting this information. And so we're really looking across the board, but we really do want it to be coming from the member, him or herself, as we feel like that is a very important aspect. We don't want to just be tying different, ancillary data sources together to suggest what someone's health needs are or who somebody is. We can get this information ourselves. And if the event, you have feedback or thoughts on how we can do that in ways that we're not, would love to hear about it.
Thank you.
Sure. Thank you. Yes.
Hi, Rebecca Antarnovic from the Legal Aid Society. Just incredibly grateful to you and everyone in the department for all of the coverage expansions that you've pushed towards. It is already, even not even implemented yet. It's making a huge difference. Want to talk about people who are covered actually getting the care they need. And I think a big concern for a lot of consumer advocates is working with people who are facing denials by their Medicaid managed care plans and really not seeing accountability for plans when they're denying things that shouldn't have been denied, and when that in itself is creating barriers to care. And haven't really seen in the waiver accountability for plans and really making sure and looking into what is happening with denials, connecting that to the race and ethnicity data and who's getting denied and who's getting through the appeal process and all of that. So just interested to hear what the department is thinking about on that.
Yeah, absolutely. And great. Thank you, Rebecca. I think there's a few different concepts you're talking about. Not all of them are appropriate through the waiver authority. We can be reinforced and will be reinforcing what we're trying to accomplish through the waiver through model contract requirements so that plans are following the standards and guidelines we expect. And I think in this instance, we're trying to tie dollars, those VBP dollars that will likely go through health plans aren't necessarily going to be released unless some criteria and standards are met. VBP generally, kind of mitigates some of the denial aspect. That's really much more of a commercial insurance fee for service concept. And we have been working with our plan partners regularly, especially in the behavioral health area. We are trying to enforce and put in new standards to ensure accountability. I just don't know that they're all going to be outlined in the 1115 waiver, which is really our goal to foster, or our vehicle to foster more innovation in delivery of care. But we will reinforce standards of care. I do want to mention on the appeals. I know you mentioned in the appeals. I think we and definitely Lisa and others on our team, including DLA, are very focused on what's happening in that. We're working with OTDA very closely. It's a very challenging problem, workforce related, but we are thinking of ways to use our administrative flexibility under the PHE to make administrative appeals and fair hearings as easy as possible for those that are pending. And I think we're going to have some information coming out in the coming weeks and months that really speak to how we're going to do that. But it is a big problem and we acknowledge that completely. Thanks. Oh, last plug before I get kicked out. Social media strategy. Marcy, we have a brand new social media strategy. The entire Department of Health does. Our communications team has put a lot of effort into it. It's wonderful. Check it out. The links are all here. And thank you again.
Thank you so much, Amir. It's such an honor to have you kick off this conference. We're going to take about a 10-minute break and we'll reconvene at 11:15 for the first panel this morning. Thank you again.